ever find yourself looking at an ECG and you're just like, what am I even looking at here?
It can definitely feel that way.
And it's like, I need a whole secret decoder ring, right?
Absolutely, especially when it comes to these tricky tachycardias.
Right, those can be tough.
And that's what we're diving into today. We're doing a deep dive on Brugada criteria.
Okay.
So this is your secret weapon, okay? To figure out if it is just a harmless little heart skip.
Right.
Or if it's the real deal ventricular tachycardia.
Yeah, that's a really common ECG puzzle.
It is.
But the good thing is there's a really nice systematic way to approach it.
Exactly. And thankfully, we have DrBarai on YouTube.
Yes.
Who breaks this down with, like, super clear visuals. So
he does a great job.
He does a great job.
Yeah, he does.
And he lays out Brugada criteria in these 4 steps.
So are we ready to, like, jump in and go through these? All right, step 1. This is all about something called concordance in the precordial leads, which sounds really complicated, but it's actually just looking for patterns.
It is.
In those squiggly lines that we see.
Yeah, so normally in the precordial leads, you see upward and downward deflections.
Okay.
And when you see both of those together, that's actually called discordance.
Discordance.
And that's what you'd expect to see normally.
I gotcha.
But in VT, because that electrical activities are just going haywire in the ventricles,
right,
those deflections in those leads, V1 through V6, they often line up.
Oh, okay.
So they're either all positive and all negative, and that's concordance.
And
that's concordance, and that is a red flag.
So it's like all the signals are pointed in the wrong direction instead of going back and forth.
Exactly.
Yeah, and DrBarai shows this one example where they were almost completely positive, those leads, across the board. And he calls it a sharp fin pattern, which like instantly stuck in my brain.
It's very visual.
So visual.
And that's crucial because VT is not something you want to miss.
Right.
If we miss VT, the consequences for the patient can be severe.
Right, exactly. Okay, so that concordance is a good starting point, but it's not always like super obvious and clear cut.
It's true.
So what's our next clue when we're looking for Brugada criteria?
So step 2 brings us to what's called the R to S interval.
Okay.
And this is a measurement that's surprisingly easy to remember. You're essentially looking at the width of that QRS complex.
Okay.
And if that QRS complex is wider than 100 milliseconds, which is about 2.5 of those little boxes on the EKG paper, that points us toward VT.
2.5 boxes, got it.
Yeah.
But what's the logic behind that?
Yeah.
Like, why is that QRS complex stretched out in VT?
So think about it this way. A normal heartbeat.
Okay.
It kind of follows a very specific route, right? Like a well-planned road trip.
Okay.
But VT, that's like the road trip going haywire. It's taking all these detours going through the back roads.
Okay.
And that roundabout route, that takes more time.
Okay.
And that shows up as a wider QRS complex on the EKG.
Oh, that makes sense. So it's like when you have those like chaotic morning commutes and there's an accident on the freeway and it's just like everything backs up. It makes you appreciate those smooth sailing commutes even more, you know?
Right.
Okay, so we've got concordance. We've got this R to S interval down. What's next?
So step 3 delves into, it sounds a little scarier than it is, but AV dissociation. AV dissociation.
Okay.
And luckily, DrBarai's analogy makes it so clear.
Yes. He does the whole happy marriage analogy.
Happy marriage analogy.
Which I feel like just makes it like so much more understandable.
So in a normal rhythm, the P wave and the QRS complex, they're connected.
Right.
They're working in sync, like a good marriage.
Okay.
But in VT, they're practically estranged.
Oh, no.
Imagine 2 cars that are supposed to be traveling together, but suddenly they're going at totally different speeds.
Right.
That's what's happening in the atria and the ventricles in VT.
So we might see P waves happening like totally separate from
Precisely. The ventricles are just generating their own rhythm in VT.
Right.
While the atria might be trying to keep up and maintain a normal pace.
Right.
That disconnect, that's AV dissociation.
Okay.
That's a major clue.
That makes so much sense.
Yeah.
I don't know about you, but that whole AV dissociation thing used to really trip me up.
Yeah.
But like thinking about it as this like visual analogy just makes it click so much more.
Makes it stick with you.
Okay, so 3 steps down.
3 down.
1 to go.
1 to go.
What is the final piece of the Brugada criteria puzzle?
So the fourth and final step is all about analyzing the morphology or the shape of the QRS complex.
And DrBarai is like upfront that this one is a little bit of a brain twister.
Yeah, it's a little more nuanced. It is. But he focuses on two main patterns that we often see in VT, right? Bundle branch block and left bundle branch block.
Right.
Now, these patterns can occur in other conditions as well.
Right.
But seeing them in the context of those other Brugada criteria really strengthens our case for VT.
Okay, so it all goes together, it all builds.
Bell builds.
Right, and he even gives us these really helpful visual cues to look for.
He does.
Like that bunny ear notch in the S wave for the right bundle branch block.
Right.
Which sounds kind of cute.
I know.
Right? But it's a serious red flag when we see it on EKG.
It is a serious red flag.
And then for that left bundle branch block, he talks about a wide R wave, stretching out more than 40 milliseconds, which is just one small box on that ECG grid.
It is.
Right, and those little details can be easy to miss.
Exactly.
But they help us pinpoint, where did that signal come from? Where's it going?
Totally. Those little details can be so revealing.
Right, and why is it going rogue like that?
Exactly.
It's like those detective shows where they're like looking at the fingerprints.
I love it.
Or the bullet trajectories.
It's all about the details.
And it's those little things that help them solve the case.
It's true.
It is.
So even though it's tempting to gloss over the morphology, just because it seems complicated, those nuances can really help us make the diagnosis.
Totally. Okay, so we just covered a lot of ground here, right?
We did.
We walked through all 4 steps of Brugada criteria.
We did.
And I have to say, like, I'm already feeling a little bit more confident in my ability to tackle those tachycardia ECGs.
That's what we like to hear.
But to really solidify this, I think we need to put this into practice.
I agree.
Right? And thankfully, DrBarai goes through a ton of real-life ECG examples.
He does.
So are you ready to put on our detective hats?
Let's do it.
And see if we can spot Brugada criteria in action?
Let's see what we can find.
Let's do it. All right, let's take a look at this first ECG. First impressions. What are you seeing here?
Well, we can definitely tell that it's a tachycardia. That rate is very fast.
Yes.
And those QRS complexes are wide, which always makes me think twice about the possibility of VT.
Right. When you see those wide QRS complexes, that's when you pull out the Brugada criteria.
Exactly.
So let's go to step 1, concordance in those precordial leads. What do you see?
Okay, so looking at leads V1 through V6, it's a little subtle, but I'm not seeing that clear pattern of all positive or all negative deflections.
Okay.
Some are leaning positive, some are leaning negative. So I wouldn't hang my hat on concordance with this one.
Okay, good point. It's good to remember that we don't always have concordance present, even in cases of VT.
Exactly.
All right, so let's go to step 2 then, that R to S interval. What's our verdict? Wider than those 2.5 little boxes.
Let's see, definitely wider than 2.5 boxes in a few of these leads, especially V3 and V4.
Okay.
That prolonged R to S interval is definitely a strong point in favor of VT.
Okay, so we've got 1 point for VT. Now let's look at step 3, that AV dissociation. Are the P wave and the QRS complex one big happy family here?
This is interesting. It's subtle because the key waves are almost hiding in these wide QRS complexes.
Right.
But if you look really closely, you can see that they're marching to the beat of their own drum, completely independent of those QRS complexes.
It's like 2 ships passing in the night.
Exactly.
So you're right, that AV dissociation is definitely there, which is adding more weight to that VT diagnosis.
I agree. And while we could certainly analyze the morphology, we've already fulfilled 2 of the major Brugada criteria here, making VT the most likely scenario.
Right.
Remember, it's about the big picture, not just checking off boxes.
Right. And this is so helpful to see it in action like this because it really highlights the value of this.
I agree.
In a clinical setting.
Absolutely.
Ready to look at the next ECG.
Let's do it. Let's see what we've got.
Okay, take a look at this one. What are you thinking?
Okay, another tachycardia, wide QRS complexes, definitely warrants a closer look. We should pull out those Brugada criteria here.
Yeah. All right, so walk me through it.
All right, well, first, notice how incredibly regular that rhythm is.
Oh, yeah.
Now, that can be another clue, although that's not part of the Brugada criteria itself, but it's something to keep in the back of your mind.
Interesting.
But let's not get ahead of ourselves. First up, concordance.
Okay, so I'm looking at V1 through V6, and yeah, there's definitely a pattern here. They all seem to have that predominantly negative deflection.
They do.
Is that our concordance?
It is, and it's a rather striking example of it, too. Remember how he said concordance is a relatively rare finding?
Yeah.
Seeing this clearly, it really makes you stop and think, VT.
Right.
But let's not jump to conclusions. We still got to go through the rest of the criteria. What about that R to S interval?
Well, given that there is that concordance, it's a little hard to see those clear-cut R and S waves, so it's going to be tough to measure accurately, wouldn't you say?
You're absolutely right, and this highlights a really crucial point. Brugada criteria, it's not a one-size-fits-all tool.
Right.
Sometimes certain steps might not be applicable because of what the ECG is showing us.
Okay, good point. It's like you always have to be thinking critically and not just blindly following the rules, basically.
Exactly.
Okay, so moving on to AV dissociation. Are those P waves playing hooky again?
You know, I am not seeing any obvious P waves in this rhythm, are you?
No, not really.
It's likely that they're buried within those wide complexes, which in itself can be a subtle hint toward AV dissociation.
Oh, interesting.
However, we can't definitively say, just based on this ECG alone.
Okay, so we've got strong concordance kind of pointing us towards VT.
Yes.
That R to S interval, it's a no-go. We can't really measure it.
Right.
And AV dissociation is possible, but we can't say for sure.
Right.
So what about morphology then? Any bunny ears or other giveaways there?
Let's see. In lead V1, we do see that predominantly negative deflection. It's giving us that classic left bundle branch block appearance.
Oh, okay.
But remember, morphology and isolation, not enough to diagnose VT.
Right. It's all about putting it all together.
Exactly.
So we've got strong evidence from that concordance. Morphology is suggestive.
Yeah.
But the R to S interval and that AV dissociation, we just don't know.
We don't know.
So what would you do in a case like this if this is what you were seeing in a patient?
Well, in a real-world scenario, you would definitely factor in their clinical presentation, medical history, other diagnostic tests, along with these ECG findings to really make a well-informed decision.
It's all about context.
Exactly.
It's not just looking at the squiggles on the paper, it's looking at the whole patient.
100%.
Oh.
These examples really highlight how important it is to be thorough and consider the entire picture.
I like that. It's not just about finding the one thing that's going to give you the answer, it's about looking at everything together.
Exactly.
All right, should we do another one?
Absolutely. The more we practice, the more confident we'll get at applying these criteria.
Love it. Okay, let's take a look at this next one. What are you seeing here?
All right. Well, this one looks a little different. Still a tachycardia, but those QRS complexes aren't quite as wide as the previous examples. What's going on here?
Yeah, I was just thinking that they're definitely narrower.
You're right on.
Yep.
So this ECG is a good reminder that not all tachycardias with wide QRS complexes are actually VT.
Right.
This particular rhythm here is an example of what we call supraventricular tachycardia, or SVT, with aberrancy.
SVT with aberrancy. Okay, so that means that the electrical signal is coming from above the ventricles.
It is.
But it's taking kind of a weird pathway.
It's taking a detour.
And that's why that QRS is looking wide.
Exactly. And this is a perfect example of why we have the Brugada criteria, because it helps us distinguish between SVT with aberrancy and true VT.
Okay, so how do we do that then?
Well, let's start with concordance. What do you see in those precordial leads?
All right, let me see. Looking at V1 through V6, I am seeing both positive and negative deflections.
Okay.
No clear pattern here.
No clear pattern, so no concordance.
No concordance.
And that right there makes us less suspicious of VT.
Okay.
Because remember, concordance is much more common in VT than it is in SVT with aberrancy.
Gotcha.
Okay, let's go into step 2. The R to S interval.
Okay.
What's our verdict?
Let's see. It is definitely less than 100 milliseconds. Well, within the normal range.
Another point against VT.
Okay.
Remember, a prolonged R to S interval, that's a hallmark of VT because of that abnormal electrical conduction through the ventricles.
Gotcha.
Okay. Now, what about AV dissociation? Are the P waves and the QRS complexes playing nicely together?
Oh, this is tough. It looks like there might be P waves buried just before those QRS complexes. They're subtle, but they seem like they're related.
You're right. Those P waves are sneaky.
Yeah.
But they're there.
They're there.
And the fact that they appear to be related to those QRS complexes suggests that the atria and the ventricles are still working together.
Okay.
Which rules out AV dissociation.
Right.
This further supports our suspicion of SVT with aberrancy rather than VT.
Wow. It really is like a puzzle putting all of these clues together to get to the answer.
It is. It is.
I love it. It makes you feel very smart when you can put it all together.
I agree. And it highlights how important it is to consider all of those steps.
Yes.
Even when the ECG might initially seem straightforward.
Right, you can't just jump to conclusions.
Exactly, you got to look at everything.
So even though this ECG was a different type of tachycardia, Brugada criteria still helped us rule out VT.
Exactly, and this brings us to a really critical point about Brugada criteria. Its limitations.
Okay, because no tool is perfect.
Exactly.
So what are some of those limitations that we should be aware of?
Well, one of the biggest pitfalls is getting tunnel vision on a single criterion.
Oh.
Remember how we said that concordance is a relatively rare finding?
Yeah.
If you're only looking for concordance, you might miss a VT diagnosis altogether.
Oh, wow.
It's crucial to consider all 4 steps in the context of the patient's entire clinical picture.
Right, you can't just focus on that one piece of the puzzle.
Exactly, you have to look at the whole thing.
Okay, so what other limitations should we keep in mind? So
another limitation is that Brugada criteria, it's mainly geared towards monomorphic VT. That's where those QRS complexes. They look pretty similar from one to the next.
Gotcha.
It's not as reliable when we're talking about polymorphic VT.
Right.
That's where the QRS complexes are changing.
Okay.
Their shape and size are different, and that often requires a different approach.
So if you see that polymorphic VT, we're looking for different clues, not necessarily those Brugada criteria.
Exactly. Polymorphic VT, it often has this chaotic appearance.
Okay.
The peaks and valleys, they're kind of twisting and turning all over the place.
Oh, wow.
It's a red flag that you really need to pay attention to.
Definitely.
It's also really important to remember that other things like electrolyte imbalances,
right,
certain medications, even underlying heart conditions, they can sometimes mimic VT on an ECG.
Oh, wow. Okay, so it's not always clear-cut.
It's not always clear-cut. You have to consider those other possibilities.
And not just get stuck on that one diagnosis, potentially.
Exactly. So think of Brugada criteria as a really important tool in your toolbox.
Okay.
But it's not the be-all, end-all of VT diagnosis.
Right. It's about combining it with everything else that you know.
100%. It's using your knowledge, your observations, your critical thinking skills.
This has been so helpful. I feel like we've really dissected this.
I agree.
Brugada criteria, we looked at examples, and then we even touched upon those limitations.
It's all about getting the whole picture.
Exactly. And I feel a lot more confident approaching these ECGs now.
That's fantastic.
And for those listening, if you want to learn more, definitely check out DrBarai's YouTube channel.
Yes, highly recommend.
He walks through so many great examples.
He does.
Really helps solidify your understanding.
He makes it so much easier to understand.
He does. But this whole discussion, it does raise a question.
It does.
So, as our final takeaway for today, what other factors, besides just the ECG, should clinicians really be thinking about when they're trying to diagnose VT?
That's the million-dollar question, isn't it? Because no diagnostic tool is perfect.
Right.
So really think about, what is the patient's history?
Okay.
What other information do you have that can help you make the most informed diagnosis?
Right. Connecting all those dots.
Connect the dots. Exactly.
It's not just about what you see in those squiggly lines. It's about the whole patient.
It really is. It's about the whole picture.
I love that. Well, this has been a fantastic deep dive.
It has.
Into this world of Brugada criteria.
It has been fun.
And I'm sure all of our listeners are going to be EKG masters after listening to this.
I hope so.
Thank you so much for joining us on this electrifying journey, and we'll catch you in the next one.